This is the November 2019 MEC Minute, and our topic for this month is the review of the 2020 protocol. So just a few basic opening comments. For the 2020 protocol, this is the review. The protocol is effective January 1st, 2020, and Gordon Griggs will have it set up so that as of first thing in the morning at 0000 hours on January 1st, your app should switch over to this new protocol. And when that happens, you should update your ResponseSoft app on your cell phone or on your tablet or laptop. And I expect and anticipate that when this change occurs and you open the app for the first time, you'll get a reminder to update. So please make that update. There's also a 2020 protocol assessment. It's a written assessment. It's in a similar fashion to what we did earlier this year. And it will come out in November, December, and with it there is a video. And everybody who functions or operates under the MEC EMS protocol must complete the assessment by the end of January 2020. I encourage group participation. I think you learn better as part of a group discussion, and often opportunities for additional training or for potential protocol revisions come up as part of these discussions. The assessment is pass-fail, but there is no passing grade. In order to pass, you have to take the written assessment either individually or as a group, and you have to review and view the entire video that Dr. Stoner and I have recorded. Your EMS coordinator will help arrange that for you. In terms of changes to the 2020 protocol, they're all identified under the list of changes that are near the back of the protocol. I believe it starts on page 320 of the protocol, and there are 4 or 5 pages of changes that have been made as part of this revision. Some of the changes are minor secretarial changes, minor updates, things that I'm not going to review today, but you may find on the list. I've got a quick list of changes that we can just run through on this one slide, and really I'm not going to give any additional detail on. First off, we removed twin cath from the protocol. So as part of our stroke protocol and our STEMI protocol, we had twin catheters identified. They were not really being used that often in the field and not often being utilized in the emergency department. So we're taking them out of the protocol. If you have quick cath or twin cath catheters in your truck or in your station, you can still use them. You can use them as peripheral IVs, and from my perspective, they are IV catheters, and you do not need special instructions or special authorization to use them. So I would use them up. We had a procedure for breech delivery. We took it out because it was complicated. It used terms that were difficult to remember, so we just took it out. Under previous discussions we've had regarding our change to DSI, we've made some changes to epinephrine infusion. So it's been modified to include using the epinephrine infusion dilution as medication that be given as an epinephrine push dose pressor, particularly for patients who are hypotensive, as part of the intubation process. Also, as part of the intubation process, we removed the Selleck maneuver or reference to cricoid pressure. It's been proven in research that it is not effective, and it actually may aggravate the view of the cords when you're trying to intubate a patient. So we have removed it. At the request of some of our providers, we added aspirin to the list of antiplatelet medications identified under head trauma. So aspirin is an antiplatelet medication just like Plavix and Brilinta. Recently, as part of our MEC Minutes, we did a discussion on the new Ohio DNR form and the DNR process. So as part of the protocol, the old form was removed and the new form was added. For our clinical standard on medication cross-check, we added correct route to be verified in addition to the correct dose, the correct medication, and so on. There had been some discussion with some of our providers in the past about whether or not the correct route was identified during an episode of patient care. For patient restraint, we added spit mask as a potential restraint that can be used. This is for patients who are violent and spitting. So it is being added. If you do have spit masks added to your protocol, you need to be aware that it's there only to protect you as a provider or the public. It's not to be used in a punitive fashion, and you have to continue to monitor the patient because we need to make sure that they maintain an airway. And if the mask is in place, our view of the airway may be impaired. And then in terms of CPAP devices, I think we had 3 different devices listed as part of our clinical procedures. Everybody's using the same device, the old-fashioned device that included the big yellow box that drained your oxygen cylinders quickly. Nobody's using those anymore. So we've pretty much removed those 2 devices that are not in use and just kept the one procedure for using the device that everybody's got on their truck. So I'd like to talk about some of the significant changes, or at least those changes that I see as significant. The first has to do with chest pain patients. We've just made a modification in terms of repeating doses of nitroglycerin. In the old protocol, we had a line or a box that said for all normotensive or hypertensive patients with chest pain, you can give 3 doses of nitro until the patient's pain is gone. We just said here that you can repeat the original dose of nitroglycerin times 2 as long as they maintain an adequate systolic blood pressure and you have IV access. The nitro-paste dosing as a concurrent application with the first dose of nitroglycerin does not change, so that's nothing new. We've just kind of reformatted what this looks like. And I think as clinicians, you're all able to understand that if the patient's still having active chest pain, you should repeat the nitroglycerin. For those departments that respond with Columbus Division of Fire as part of mutual aid agreements and who may have the mobile stroke treatment unit arrive on scene, I have added that to the protocol. This essentially is a reiteration of what I sent out as an addendum to the 2019 protocol back in June. So what was previously being done as an addendum to the protocol has now been incorporated into the protocol. So there's no real change in terms of content. It's just now this is officially part of our protocol. We've made changes and adjustments in seizures. I recently did a MEC minute on what we were considering to do with seizures and how we manage seizures. So I'm going to talk about adult and pediatric, and they are very similar in terms of our revised approach. So the first thing in terms of adult seizures is we have moved administration of midazolam to the top of the protocol so that if you walk into the room and a patient is having an active seizure, we're going to put them in a rescue position and we're going to administer midazolam. So in the past, we have used midazolam intranasally. As part of the 2020 protocol, we're adding that you can use the same dose as an intramuscular injection. So you walk in the room, excuse me, the patient's having a active seizure. You can decide to give the patient a dose of midazolam as an intranasal administration or as an intramuscular route of administration. Same dose, same medication, same concentration, just 2 different options in terms of how we're going to administer it. At the bottom of the the seizure protocol for adults, we've modified it somewhat in that we have patients that either have an ongoing seizure, so that we would consider them to be in status. That would be the left-hand column. Or in the right-hand column, they are postictal on your arrival or they're awake on your arrival but have a recurrent seizure. In either case, we're going to treat them the same. We're going to give them midazolam as either an intramuscular or intranasal dose. Or we can give them as an IV or IO dose of midazolam. The midazolam dose has been adjusted upward. It's obvious that physicians and EMS providers have been underdosing benzodiazepine for patients who are in active seizures. So our midazolam dose for IV use in the case of an active seizure is 4 milligrams. The intranasal and intramuscular dose remains at 10 milligrams. And if the seizure persists or if it recurs, we can give the patient a second dose of midazolam. That second dose, the preference is for it to be given IV or IO, and that is the repeat of 4 milligrams. Same thing is true if the patient is postictal but then has more seizures. We're going to follow a very similar thought process in terms of medication and how we are going to administer it. As I discussed in, I believe it was my August MEC minute, we are now going to add ketamine as our backup medication for patients who have ongoing persistent seizures despite 2 doses of midazolam. So we're going to administer 1 milligram per kilogram of ketamine, either IV or IO. It is not indicated to be given IM or in, so no nasal or intramuscular ketamine for patients in active seizures. I have really no information in the literature to support either of those methods of administration for patients in status epilepticus. So we are treating these patients for status epilepticus with ketamine IV. I caution you to be careful that if we've already given the patient 8 milligrams of IV midazolam or additional doses of intranasal plus IV midazolam, this dose of ketamine puts them at significant risk for respiratory depression, so we should anticipate having to support the patient's ventilations. If the patient requires a iGel or endotracheal tube or BVM support of their respirations, that's not a complication of therapy. That's an expected potential outcome of our therapy. We should be prepared to provide that assistance for our patients. So if you're getting out the ketamine for the patient in status epilepticus, then have your airway equipment out and ready to go in case you need it. Similar approach to children. We are going to make administration of midazolam a priority. So we have in the past used the intranasal dosing that's under the MAD procedure, and I did not copy and paste that as part of the slide deck. But again, if you walk in the room, child's having a seizure, you can give a dose of intranasal midazolam. But what we've added as an alternative to intranasal is intramuscular midazolam at a dosing schedule of 0.3 milligrams per kilogram to a maximum of 6 milligrams IM. So we're going to make intramuscular midazolam as an option for you to use in children having active seizures on your arrival. We want to make that as a priority because, as I discussed in my previous MEC Minute, our priority should be to stop the seizure. So we'll do whatever we can, and the sooner we get midazolam into the patient, hopefully the sooner that seizure will end. So we have added also as treatment for seizures in a child, if the seizure continues, we have a similar format to what we're doing with the adults. So for children, if they have ongoing seizures, we can give them midazolam as a intranasal administration, or we can give them 0.3 milligrams per kilogram IM to the maximum of 6. Or if we have IV or IO access, we can give midazolam at a dose of 0.2 milligrams per kilogram up to a maximum of 4 milligrams, so essentially up to the full adult dose. Again, we can repeat it just like we can adults, and if the patient remains in status, we can give the patient intravenous or intraosseous ketamine, again, at the same dose of 1 milligram per kilogram, and we should also still be prepared to support the patient's respirations. So this, I think, is a big change in how we manage patients. The days of giving a couple doses of midazolam and the patient still seizing, and the best we can do is get them to the hospital. Now we've got that backup drug of ketamine that we'll use for patients who are truly in status. And as a reminder, definition of status epilepticus for us is patients who have ongoing seizure for 30 minutes or more, or who have had a seizure, they are postictal, do not regain full consciousness, and then have a second seizure. For us, if we arrive on scene and the patient is having a seizure, we should consider them in status because the patient's probably been having a seizure for at least 10 minutes, and we don't want to wait a full 30 minutes before we stop that seizure. So you arrive on scene, patient's having a seizure, we're going to treat them aggressively and we're going to stop that seizure. For adult allergic reactions, really no change in medication, but what we have done is epinephrine is now to be given as soon as you have an opportunity to evaluate the patient. So if the patient is having a true allergic reaction, we give them epinephrine at a dose of 0.3 to 0.5 milligrams per kilogram, and that's the 1 to 1,000. So that's the small glass vial that we crack open. And then we can repeat it. So our first priority is to get epinephrine into the patient. Another option is if the patient has their EpiPen, you can use their EpiPen if they have not already used it. This is really similar to the algorithm we have for children, but the priority is to get epinephrine into the patient if we suspect an acute allergic reaction. And we should give epinephrine whether the patient is 30 years old or 70 years old, if the patient has a history of coronary artery disease or not. If they need epinephrine, they need epinephrine, and we do not withhold it. Just a mention of DSI. So last month's MEC Minute was about DSI. I'm not going to spend another 15 minutes talking about it again, but be aware that DSI process goes into effect the 1st of January. I look to the EMS coordinators to assure that everyone is fully trained and works as a team and as a crew, so that if a patient has to be intubated, everybody knows how to set up the tower of power, get the patient on BVM with a PEEP valve, get the patient oxygenated, sedated, and intubated. So if you have any additional questions about this, please let me know or post it on Workplace, because this is a significant change for how we do things. It slows down the intubation process by a couple minutes, and it requires a bit of a mind reset in terms of how we approach our patients who require an airway. We have made some changes to trauma triage, and really all we did is we previously had used a diagram or a chart from COTS. It was really pretty cumbersome. What we have added or done is we have taken the trauma triage algorithm from the Ohio Department of Public Safety, or the Ohio Division of EMS, and I find it to be much clearer than what we had from COTS. So there's no change in terms of what qualifies a patient for trauma center transport. It's more a matter of format and appearance. So if we look at those things that are age dependent, children versus adult versus geriatrics, those things are outlined at the top. Otherwise, the algorithm is pretty much essential for all patients. Take a look at this, particularly the discriminators for pediatric triage and geriatric triage, and again, give special extra focus on the older patients and what qualifies them for transport to a trauma facility. So that is there. Please take a look at it. I find it to be a much better decision tree than what we had from COTS. So we've gone from 3 pages from COTS to 1 page. We've also added as supplemental material to the trauma triage process a quote out of Ohio Revised Code regarding the definition of a traumatic brain injury. This was done at the request of several of our EMS coordinators, because there have been questions about, what is a TBI. So the definition is right here. This is right out of Ohio Revised Code, and TBI means signs of external trauma and physiologic indicators that the brain has suffered an injury caused by an external force, but not limited to alteration at LOC from the patient's baseline, unequal pupils, blurred vision, severe or persistent headache, nausea and vomiting, or any other change in neurologic status. So this is there for reference. I think for me, the bottom line, if the patient is any way other than normal or at baseline and they've had a head injury, they have had a TBI. But this spells it out based on what's defined by the Ohio Revised Code. For adult and pediatric behaviorals, no change in process. All we've done is clarified what is a violent or combative patient versus a patient that's agitated. So in the previous version of the protocol, patients got ketamine if they were identified as agitated and combative. We have just simplified that to a patient who is violent or combative, and they're an adult. They get ketamine if they're agitated, meaning they're pacing, they're anxious, they're upset, and then we're going to start with midazolam. So hopefully that is clear. For children, we modified it even a little bit more. So we basically said violent or behavior, patient exhibiting violent or behavior that placed the patient or others at risk for injury. You could kind of use the same definition for adults. So for me, the difference between an agitated patient and a violent patient is the potential risk for injury to the patient or the care providers or to the public. So that's just a point of clarification. Just a minor adjustment to our pediatric airway algorithm. Dr. Stoner asked that we add a note to the pediatric airway algorithm. It says kids and babies depend on their nose to breathe. Adding a suction or a nasopharyngeal airway may help patients in their respiratory status. So, children that are short of breath, they have to be able to breathe through their nose. So, keep the nose clear, whether that requires suctioning or adding a nasal trumpet. Not a big change. I think it's common practice, but we just added it to the protocol. We added, at the request of our providers, a protocol for management of pediatric patients post-arrest. In our current protocol, we have a algorithm to cover adults post-arrest. So there was discussion about should we add one for pediatric post-arrest patients. We don't have a lot of pediatric arrests, and we have even fewer pediatric patients that are post-arrest. But we thought that was a good thing to do, so we have added this as a protocol. And essentially, it is routine things, considering fluid bolus if they're hypotensive, consider epinephrine drip per the epinephrine protocol if they need it to maintain an adequate blood pressure, and treating bradycardia as per the pediatric bradycardia protocol. So not a lot of big surprises, just an added algorithm that hopefully can help you in the field if you had a child who's post-arrest. Another thing we did at the we have made some minor revisions to various clinical standards. The one I would like to talk about specifically at this point has to do with controlling protocol and in-charge paramedic. This has been in place for years, but we added a third paragraph under application indicating that patient safety is paramount, and really making all providers on scene responsible for patient safety. If you as a provider on scene and identify a potential error in patient care or a deviation from the protocol, the expectation is you speak up even if you are not in charge. We've had a couple cases over the past year where we've had adverse events in the field, and there was some concern by the provider who was not in charge that they weren't to speak up because the in-charge medic was responsible. Well, we are all responsible for patient safety. Right? We need to be clear on that. It's not acceptable that any of us allow someone else to make a mistake that's to the detriment of the patient or even crew members or the public. So if you identify or are aware of something that may be unsafe or may be outside of the protocol or a simple error, and we all make errors, you are expected to speak up. So this is all in the interest of safety. The last thing I want to talk about is TPA, Altepace or TPA. It's the clot buster, it's the thrombolytic. We have TPA listed in our section on supplemental medications. These are medications that are not part of the protocol, but you may come across if you are asked to provide a 911 emergent transport from one facility to another, particularly a freestanding ED to a stroke center or other specialty care facilities. TPA for what we are doing is usually going to be a stroke patient who meets criteria for TPA. TPA is also used for patients who have massive pulmonary emboli and are hemodynamically unstable. But I think for emergent 911 transfers from one facility to another, the most likely circumstance that you see a patient on TPA is a patient who's had a stroke. And the only significant change we've made to this from last year or our current process is we added a statement at the bottom that if the patient is receiving TPA and they've had a diagnosis of stroke and they have an acute change in their mental status or they start complaining of headache, turn off the TPA. So TPA increases the risk for bleeding into the brain associated with a ischemic stroke. If the patient now is complaining of headache they didn't have before the TPA was started, then we should be concerned that the patients suffered an acute bleed into the brain resulting in the headache. Same thing with an abrupt change in mental status. So if they have gone from being awake, although they may have symptoms of stroke, but they're awake or they're breathing on their own, and now they become less responsive and the TPA is infusing, then turn the TPA off, manage the acute problem if it needs to be managed, such as supporting the airway, get them to the receiving facility. As part of your report to the receiving facility, let them know that the patient has developed this acute complication, and that gives them a heads up that they might need to prepare. If you've already given a report and there's a change, we'll make a second report, call back, and let them know, hey, the patient's now complaining of a headache, they are now altered and different from when we first saw them, we're turning off the TPA. So we just added that as a caution for those providers who may come across TPA. So finally, thank you for listening. Please review the protocol changes before the first of the year. Please practice DSI with your other crew members. This should become second nature for you. I know that it's going to slow down your process, but I think it's to the benefit of your patients for the reasons I explained as part of the MEC Minute last month. And then complete the written protocol assessment and view the protocol assessment video that Dr. Stoner and I have recorded. Do that, actually it says January 1st, it should be January 31st, 2020. So again, you need to complete the protocol assessment and view the video by January 31st, not January 1st. You do need to review protocol changes, but for the first of the year because that's when they come into effect. Again, thank you. If you have any questions, send me an email, but better yet, post them on Workplace. Request of Dr. Stoner is we revised our protocol for pediatric tachycardia. And it's basically, again, not a whole big change in substance. It's more a change in format. And the format is now in line with what has been in the American Heart Association's ACLS protocol for children with tachycardia as outlined in their 2015 ACLS guidelines. So the nomenclature should look much similar or very similar to what you might see in PALS or ACLS teachings. So there's no real new surprises here, but just take a look at it, review it, become familiar with the terminology. We do include amiodarone for children, which is very unusual, and really online medical control is required for that before you administer it. We do talk about adenosine, and we do talk about vagal maneuvers. We have a clinical procedure for vagal maneuvers, and I, as preparing for this talk, noticed that use of ice packs on the face for children in SVT was not part of it, so I've asked Gordon to make some modifications, and Dr. Stoner actually talks a bit about using the duct diving reflex and ice packs to the face as part of our protocol assessment review. So look for that when the 2020 written protocol is released for your review. So it's mostly an update in terms of format. For you as a pediatric or as a provider to pediatric patients, shouldn't be any significant changes in terms of content or actions you're expected to perform.